Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful Cape Town. My name is Peter de Jong, and unfortunately, Professor Steve Jeffrey is unable to join us this afternoon, but fortunately, we are joined by Dr. Zoe Momberg, a maternal fetal specialist, and she's doing a talk on placental biochemistry and the prediction of placental insufficiency, understanding normal and abnormal results in aneuploid and euploid fetuses using biochemistry to triage patients to sonographers for MFM or for the NT scan. So this is something of hands-on importance to all of us, and again, something that's very practical to the jobbing obstetrician gynecologists in Cape Town and of course beyond. Dr. Zoe Momberg is the new co-director at the Fetal Assessment Center in Claremont and a maternal fetal specialist. She's been with UCT for many, many years and head of fetal medicine at Grootsky Hospital, indeed. So it's great pleasure that we have Dr. Zoe Momberg with us. Remember that we're getting to the end of the season. It's season 5, and we're coming this year to the end of season 5. Next week, we have Dr. Percy Moodley, and he's presenting on the latest updates on the menopause subject in women. That's going to be sponsored by Bayer, and this afternoon we're sponsored by the Pelvic Floor Foundation of South Africa. On a separate note, if you don't get your questions and answers for CPD, remember to pop an email to info@pffsa.org, and Wendy will be more than happy to sort you out. So, ladies and gentlemen, without further waste of time, I present to you Dr. Zoe Momberg, maternal fetal specialist. Zoe, are you with us?
Yes, I am. Thanks, Pete. Thanks very much. Thanks for the introduction. Hopefully, am I coming through? Can everyone hear me?
Loud and clear. Zoe, okay. We not only can hear you, we can also see you, which is just an added bonus.
Okay, all right. Guys, I wanted to try and make this as practical as possible, and sharing, going back to an old set of tests that we're very familiar with. So it's not the very new cutting edge, because for the last 5 or 10 years, all of the talk about screening for aneuploidies has been about NIPT, and I think we know quite a lot about that. But I thought it's good to visit our old friend, the placental biochemistry that we all order frequently on our standard antenatal bloods, and to look if we can maybe repurpose an old test. And one of the reasons I was keen in looking into this for myself is because we always train in the state sector in South Africa, where we have very little access to placental biochemistry testing. So then you go into the private sector and you're expected to incorporate these tests into your practice, and you order them because your friends are ordering them, because your patients requested you to order them, and you actually don't have much experience with them. So even as an MFM, I had some theoretical knowledge about them, but not a hell of a lot of practical experience. So I thought it would be a good idea to look at understanding these tests a little bit better, so we can interpret them a bit better. Okay. So as a starting point, you know that placental biochemistry, or first trimester Downs bloods, as all of our secretaries call them, they're part of the screening test for aneuploidy. So we'd usually have placental biochemistry, then add our ultrasound markers, and then the NIPT as well, for highly accurate testing. So just to give you an idea that these hormones were originally included into aneuploidy testing because they improve the detection rate. So if you take maternal age for detection rate of Down syndrome, you're only going to pick up 30% of cases, because most women who are having children are, let's say, under the age of 37. So you're going to miss a lot of the Downs in younger women. So adding the free beta-HCG and the PAP-A, pregnancy-associated plasma protein A, will double your detection rate to 60%. Then if we add ultrasound markers as well, we'll further improve our detection rate. So that's where it came from. Just interestingly, in South African data, this was very nice data collected by Lo Pistorius and was published in SAMJ about, in the South African context, screening for trisomy 21 Down syndrome using the laboratory-based alpha software and comparing that to Fetal Medicine Foundation algorithm, which includes the NT measurement. And what is quite surprising, and I don't think everybody was expecting to find, is the detection rate for trisomy 21 just using placental biochemistry is quite high. It's 94%, which is similar or identical to if you add ultrasound features, including the nasal bone, the NT. So as a bunch of scanners, we're like, well, okay, we could just get replaced by some biochemical tests. But the issue is that if you just use the alpha software, you're going to get quite a high screen positive rate. So of all the patients that you order these tests on, 12% of them are going to come back as positive for Down syndrome. And obviously the Down syndrome or positive screening high risk for Down syndrome. And obviously the Down syndrome incidence is much less than 12% in the general population.
Zoe, sorry, can you just go back one? We've had some questions. People want to take a picture of the previous slide. That's the one. Yeah, sure. They want that one. Sorry, I just want to give them an opportunity to take that picture. There we go. Thanks very much, Zoe.
Yeah, perfect. Okay. So this is what I thought was most interesting from that study. You get a 12% false positive rate, and then they come to us scared out of their minds because they've screened positive or they've screened high risk for Down syndrome. And then we do the NT scan and everything is absolutely great. And we will still get a 4% screen positive rate, but at least we can give them a reasonable amount of reassurance that they're not ultrasound features. And that's a bit of a different talk, but then you can go onto your NIPT for your intermediate risk ladies, etc. But it's interesting just to compare the two alpha software only, so placental hormones only, versus adding that to the NT, the NT scan. Okay. So to understand where I'm going with this, to look at pregnancy outcome, just a little bit of background about those hormones. So the PAP-A, and it's the free beta-HCG, it's not the total. To understand the trends with gestation or at the end of the first trimester, between 10 and 14 weeks, PAP-A slowly rises, and the free beta is quite high at 10 weeks and then slowly plateaus. So they're working in opposite directions in a normal pregnancy. Okay, so what happens in trisomy 21 is these babies have lower levels of the PAP-A, and their placentas are making lower levels of PAP-A, and the unaffected or chromosomally normal babies will have higher levels of PAP-A. So you can see there's quite a lot of overlap here between normal and abnormal. So it's obviously not a diagnostic test, it's screening. But this scenario, I noticed more and more practically that we were getting a lot of ladies with low PAP-As. And so causing quite a bit of an anxiety. And now what do we do going forward? How do we resolve this issue? This is quite a nice theoretical concept, and it helps understand exactly where I'm going with this. If we look at, so PAP-A is on the x-axis and free beta is on the y-axis. And there should be, in a normal pregnancy, a 1-to-1 ratio. So the free beta and the PAP-A should be 1-to-1. In trisomy 21, you can either get a raised free beta or sometimes a lower PAP-A. So there's also quite a lot of overlap here between normal and trisomy 21. So we can't use those hormone levels alone, and that's why you get a high false positive rate. But what is most important here is the trisomy 13 and trisomy 18. Both of these lethal abnormalities have got low rates of free beta and low levels of PAP-A. So both of those conditions have placentas that don't actually work very well. So, and this is the reason why both of these have a high antenatal fetal loss rate. It's not usually because of their structural abnormalities. It's actually because their placentas aren't working. So, you know, if with a confirmed trisomy 13 or 18, there's quite a significant miscarriage and stillbirth rate antepartum. So this has nothing to do with postnatal apnea or the cardiac abnormalities. Prenatally, they demise in utero or intrapartum because their placentas don't work. So I think that's an important concept to kind of understand. So in the screening for aneuploidy pregnancies, we're looking at the free beta and the PAP-A ratios. And in trisomy 21, like I said, the free beta is raised and the PAP-A is low. But a low PAP-A can occur in euploid pregnancies, so chromosomally normal babies who are destined to have early onset preeclampsia or growth restriction. And I think that's really one of my most important points that I would like to get across today, is that you can have an abnormal PAP-A level in a euploid fetus, but you're not completely reassured because this pregnancy is going to have complications. So everyone has said, well, now we've got NIPT, why even bother with even pulling those other bloods? Because it's more expense, it's another blood draw. It's still useful in the context of a patient who's had a 10-week NIPT. We know we've excluded the aneuploidies, but now we're using those bloods to screen for early onset preeclampsia and growth restriction. It's also useful in couples who wouldn't consider terminating for Down syndrome. So they say they're not interested in screening for Down syndrome. Why do they have to do the tests? And this is, it's an assessment of placental health in those patients. So if this ratio, the alpha software will just look at the ratio, it doesn't look at the absolute values. So high free beta or moderately high and a low PAP-A, it's going to label you as high risk for T21. But it might be due to a very average or normal free beta level, but this low PAP-A. So you need to have a bit of thinking because the software won't be able to tease that out for you. Obviously, more advanced software, AI, would do this easily, but just not the alpha software in its current form. Okay. And importantly, to think that we are taking these bloods anyway in the majority of patients. So if they're providing extra data, it's good to understand what else they can offer. So this we know, but to understand how, why placentas with low levels of these hormones fail, we know beta HCG well. It induces angiogenesis in the uterine vasculature, promotes fusion of the cytotrophoblast and differentiation into the syncytiotrophoblast. So things that are really important for adequate placental function, and facilitates uterine growth in parallel to the fetal growth. Okay, we all know it does good things in pregnancy, but this is sort of the nuts and bolts of it. So if you've got a low free beta, like in a trisomy 18, the placenta is not going to do these functions very well. If we look at PAP-A, so remember the pregnancy-associated plasma protein A, it's actually a cleavage protease, and it releases insulin-like growth factor. And we know now how important insulin-like growth factors are in everything. But insulin-like growth factor stimulates mitosis, differentiation, and trophoblastic invasion into the decidua. So you can see how a low PAP-A is going to be detrimental to a chromosomally normal pregnancy. Okay, so just some practical things of when to draw these first trimester biochemistries. 10 to 14 weeks is the most accurate time to draw them. And that's because that's a time when the aneuploid fetuses have the biggest difference in their hormone levels compared to euploid. So it's most accurate at 10 weeks. If you pull them very early or very late, we can't combine them into the algorithms. So Alpha software or FMF software just won't use these blood results. So it's important. You don't want to waste these tests and then we can't use them at all. So I think I'd also like to take home the message that don't request these bloods at 6 to 8 weeks. The patient's found out she's pregnant on the pee stick last night, and now in a blind panic, she wants to go and take her booking bloods. I think you can do a single blood draw at 10 weeks. I don't think finding out booking bloods before 10 weeks is going to detrimentally change any pregnancy management, whether it's syphilis, HIV, whether it's blood type. It's not going to make a difference to that outcome of the pregnancy if you wait until drawing all of your booking bloods at the same time at 10 weeks. Okay. So as a general gynae, I don't think it's particularly important that you sort of know the patterns of these biochemistry results in the aneuploidies, but just to back of your mind, trisomy 21 is raised free beta and lower PAP-A, and trisomy 13 and 18 is low level of both of those hormones. And just remember that that's why these pregnancies fail. Okay. If you're particularly interested, it's quite good to know that these mostly work in moms, so multiples of the mean, and we have moms of lots of other points in medicine. And basically, if you want a normal mom, you want a result of 1, which means close to average. Okay, so above 1 would be a high mom, below 1 would be a low mom. So we mostly know this about the MCA PSV. But you can see this mom in trisomy 21, it's a high free beta, twice the normal level, and a low PAP-A of 0.5. So just to give you an idea, low levels for trisomy 13 and 18 of both of those hormones. But you don't have to worry about memorizing or knowing the levels for each point of gestation, because all the laboratories will work out the moms for you. You just have to give the moms weight and an accurate or within reason gestation. It could probably be 1, maybe 2 weeks out. It'll still be fairly accurate. This is what I'm going to emphasize today, that in placental insufficiency, early onset placental insufficiency, you could start detecting this because of these mom levels. So the free beta HCG might be normal, but your PAP-A is going to be low. So the 0.7 is lower than the mom of 1, which we would like, which would be normal. Okay. So to illustrate this point, this is a very common clinical scenario that I get presented with. Sorry, I don't know if we want to do maybe some questions at that point. Should I keep going?
I'm just going to see Zoe. None on the board at the moment. Thank you. If you can just carry on, yeah.
Okay, it's good because that's all the background stuff. It's the more academic stuff.
Right.
Okay.
Excellent. And we just to help you, we've got hundreds of people logged on this afternoon. Don't have a look at the numbers. Zoe.
No, please don't tell me that. That's exactly what I don't want to know.
No, I won't tell you that. I won't tell you that.
All right, so this is a typical case scenario which I get. Definitely, I'm a referral center for the high-risk cases, and we get a lot of patients from fertility centers. So I understand it's a biased view, but I'm not joking. Between 1 or 3 times a day, I get a similar scenario to this. So you get a 37-year-old who's in the advanced maternal age spectrum. This is an IVF conception, so very precious pregnancy. They've had 5 scans already. They transferred a single embryo. It's a fresh cycle. So the eggs are 37-year-old eggs. Her BMI is raised at 42. her mean arterial pressure is 110, so which is slightly raised, and I'm seeing her at 13 weeks and 1 day. Then I look at her free beta, just her standard lab report. I don't even look at these. I don't know what normal is for gestation because they're all taken at different gestations, and it depends on the mom's weight. But what I'm looking at is the moms. So I know I want a mom of 1, and her free beta is 1.2. It's slightly raised, but nothing properly scary. And then her PAPA is 0.7, which is a little bit on the low side. But now what the alpha software will do, it doesn't look at the absolute values. It's going to say 1.2 is nearly double 0.7. And then it flashes the lights, high risk for T21. And this woman walks into my office. You can see the tears welling up as she walks in the door. She is shaking. She can't even, because now she's looked on the pathology portals and she looked at her results. And now it says higher risk for T21. She is certain this is T21 and she wants to talk about termination options. And this is an IVF pregnancy, remember. Okay. So now some of my job is to try and sort out, is she actually high risk for trisomy 21 or is this actual placental insufficiency? Because her age-related risk for T21 being 37 is 1 in 151. And then we've added her biochemistry, and it's down risk to her a bit, but she's actually still in the high risk category. She's higher than 1 in 300. This hasn't helped me a lot. I'm not particularly reassured by these numbers, and I'm like, we in the gray zone, we in a bit of risky territory here. Like I say, we haven't significantly down risked her. So then we do our scan, and we find a beautiful nasal bone, nice and thin NT. The ductus venosus is perfect. This is textbook baby that's looking very much not like a Down syndrome baby. Okay, so this is where we can decrease our false positives. Definitely, we know that we can't pick up every single baby with Down syndrome on scan, but the scan findings are quite reassuring. And this is not like slam dunk Downs at all. So at this point, we'll be able to down risk her. So I'm going to then do the combined risk, which is her age and the biochemistry and my ultrasound findings. And I managed to down risk her to 1 in 1,900, which was considered low risk. But there's a 95% detection rate. And sometimes in these cases where you intermediate risk on biochemistry, we will then offer them NIPT as well for additional reassurance because now they are so freaked out about this Down syndrome story. But then she'll say, okay, fine. So we do the NIPT and that will really exclude the T21. But why is my PAP-A low? Why did I screen increased risk? And then we say, well, let's look at why your PAP-A is low. So then we've done the mean arterial pressure already. It's a little bit raised. And we look at her uterine arteries and Dopplers. And then she tells you that she was born at 32 weeks because her mom had a blood pressure problem. She doesn't know what it is, but that's the history she can give you. And we do her uterine artery Dopplers, and there's sky-high resistance or pulsatility index. And combined with that low PAP-A, she actually screens ultra-high risk for early onset placental insufficiency and preeclampsia. Just to give you an idea, this is high resistance, low flow in the uterine arteries, and this is much better flow, lower resistance. This is a more healthy placenta. And then we can say, well, let's protect your investment. You've spent a lot of money on this IVF. Why don't you get aspirin, low-dose aspirin from now, and then you don't need to deliver 26 weeks and then add the ICU costs on top of that. So then the patient has an understanding because they really want to interrogate every single aspect of the screening and testing. So then we have a very satisfactory explanation for why she screened high risk for Downs. Yes, she's got to wait 10 days for her NIPT result, but we can say to her, the baby is really looking very good on scan. I think we can be quite reassured you can sleep tonight, but we can look for another cause for why you screened like that, and we can manage the placental problem. Okay.
Zoe, sorry, can I come in over here? There's the questions are, I don't want to leave too many out. Innocent Wafa says, what are the other maternal factors that can affect the levels, i.e. can BMI affect the levels or not? Body mass index.
Yeah. So I think definitely they do. And all of the laboratories will ask you to put in maternal weight in requesting them. So they'll put their, they come back as a concentration, IU per liter. So these are like nano or picoparticles per liter. And they need maternal BMI. And definitely the higher BMI will cause, often give you lower levels. But it's not the same as NIPT, because we often say, well, there's not enough fetal fraction because because of high maternal BMI. I think to an extent, yes, but obese patients, obesity itself is a risk factor for placental insufficiency. So they're getting low PAP-As because their placenta hasn't infiltrated the endometrium adequately, and they are going to become a risk for placental insufficiency, and that's often why the PAP-A is low.
Okay, thank you. Another question from Katrina Matras. Do you use RI or PI for uterine arteries?
For uterine arteries, I think we use PI, and I think everything is moving away from the RI, even in umbilical artery Dopplers. We still definitely report on them, but for uterine, it's definitely PI. So
Thank you.
The pulsatility index, it's the difference between the peak systolic and the average diastolic flow. So you can see that. Yeah. And this is a better one, a healthier placenta or healthier uterine arteries on the right of the screen. Okay. So I wasn't aware about the interest in looking at this first trimester biochemistry for pregnancy outcomes in euploid fetuses. I thought they were just used for screening for aneuploidies, and that was that. But interestingly, now everything I'm going to speak about from now onwards is about euploid fetuses. So all the research that's been done is we've already checked out, we've excluded the T21s, the T13s and 18s. These are the subjects in these journal articles are only babies that have been proven to be chromosomally normal, either on NIPT or invasive testing. But it's fairly recent research, actually, because these tests, the free beta and the PAP-A, have been around really for a long time, like probably in mainstream, maybe some of the more experienced, like 30 years, maybe 40 years, we've been doing these. And you're seeing more recent research. Okay, interesting. I didn't know there was a Macedonian medical journal, but 2018 is not like donkey's years ago. This is more current research and looking at obstetric outcomes with these low levels of PAP-A in euploid fetuses. We obviously know the T13s and the T18s aren't going to do well. And that's not what this research is about. And then also the mathematicians and the biostatisticians have always got to they have to show that they are needed and they've got jobs. I highly recommend that you do not read this article. It's heavy maths and logarithmic regression but this is 2021, looking at for trying to predict small for gestational babies from their biophysical profile and biochemical markers. So, the screening for early onset growth restriction at the 13-week scan is not new, and these algorithms are there, and Fetal Medicine Foundation has promoted screening for early onset disease for a long time. The problem with that, which I find, is that you need to do first trimester uterine artery Dopplers, and definitely that's a great idea, and if you have access to that, all for that, and I'm happy to do them for you, but I also find them difficult to do. And, you know, in your BMI of 40, it's sometimes I've had to admit defeat. I cannot find those things on abdominal scanning. So let's look at other ways we can predict for early onset growth restriction in women who don't have access to those uterine artery Dopplers. And this was looking at the biochemical marker. Yeah.
Here's a question just before we look at the other ways. Akan Akapan says, what's the ideal gestational age range for measuring the nuchal translucency? When should you? Where's the best time? What gestational
age? So what the algorithm says is, hold on, 11 weeks, 0 days to 13 and 6. That's okay. The algorithm will do. But I think 12 and a half weeks to 13 and a half weeks is better because you can see anatomy better than you can just at 11 weeks. So to book an NT scan, I would book it at 12 and a half to 13 and a half weeks. And we usually try and book them at 13 and a half weeks, just in case there's a problem with the dating and the patient's a bit further than that. Hopefully
Thank you. Yep, I'm sure that answers his question.
Okay. All right. So don't read this article, I'm going to tell you. Basically, they were looking at detection rates of small for gestational age baby, and they're looking at a proper obstetric outcome if the baby needed to be delivered before 32 weeks because of growth restriction. So it's not something soft and fluffy. We don't deliver before 32 weeks unless we've got a proper indication. And they looked at maternal factors, mean arterial pressure, uterine artery, PIs. Adding the PAP-A will give you an area under the curve of 79%. So that's a fairly good accuracy for predicting that. And also adding the PLGF definitely improves accuracy up to 82%. The issue with PLGF, placental-like growth factor, it is becoming more available in South Africa, probably in the last 2 years or so at the major labs. But it's about, that test alone is about 1,000 Rand, and the medical aids at the moment haven't come on board with refunding that. The free beta HCG and PAP-A, they definitely will. So this is saying that maybe just looking, adding these placental hormones is a good way of looking for small for gestation, and they're all different kinds of things that you can do, but the numbers are pretty solid, 60,000 pregnancies. And they looked at different ways of what is a good predictor of small for gestational age. And then in the fetal medicine community, we always have a fight about what is small for gestation. Is it less than 10%, less than the third? But so they looked at it all different cutoffs. You can use Z scores, don't worry about that. But predicting small for gestation, it improves with the severity of the disease. So the earlier and earlier that you have to deliver, or the greater the smallness of the baby, coexistence of preeclampsia, and the increased number of biomarkers and how abnormal those biomarkers are. So I think there's accumulating evidence that shows you it's I know it's multifactorial. You can't say it's causal, but if you've got a PAP-A in the boots, a very low PAP-A, you can be quite confident that this pregnancy is going to run into trouble with growth. So then there's more and more stuff being published on this all the time. And then I was looking 2020. This is new-ish research that's re-looking at blood tests we've been doing for 30 years and looking, can we risk stratify for early growth restriction? Just as an aside, if you're scanning it or screening at 13 weeks, you are going to be looking for early onset disease where there are fewer women affected by it, but the results are devastating. If you have to deliver at 26 weeks, everyone knows that that's a disaster. So doing this is not going to help you detect late onset growth restriction. So I'm talking about 36, 37 weeks. It can't do that, and it's not going to be useful for that. But interesting, this is in mainstream research. I mean, this is in Nature research. So this is not even obstetric community, this is outside the medical community. Obviously, it's good bioinformatics and maths and things, but yeah. So what they are saying, they've called it abnormal maternal serum biomarkers, very low PAP-A or a high free beta. Then they've chucked out all of the genetically abnormal, chromosomally abnormal babies, and now we're just looking at euploid fetuses. And what they realized is you will definitely get a high false positive rate. So in South Africa, it might be 12%. So then they looked in the mid-trimester at the Manchester Antenatal Vascular Service, which I think is so interesting because they realized that this is a placental vascular problem. And then they did something called a placental screen at 21 to 24 weeks. And the thing with this is, so an incidental finding of these abnormal markers, we've sorted out the aneuploidies, and they're coming back anyway for their anatomy scan. So these ladies are going to get a scan anyway. At that scan, they looked at the umbilical artery Doppler, the uterine arteries again, fetal weight, placental biometry and volume. I'm not recommending you do all of those things, but then you can triage and say, hey, who is going to truly have a problem, peri-viability, or who can we forget about and only do a growth scan at 32, 34 weeks? And we see this time and time again, where if the uterine arteries, there's high resistance at the anatomy scan, even though they're on Ecotrin, we can tell them that those ladies are going to deliver at 30 weeks or before, because it really does show you that there is a problem coming. So I would recommend, incorporating the uterine artery Dopplers at the 20-week scan. Also, not the easiest thing to do, but remember they are getting a scan anyway. And definitely, even if you're referring to sonographers, you should ask to get those incorporated. So a little bit of math, but I just have to say there is evidence for what I'm talking about. If they took their ladies who've got abnormal placental biochemistry, and then they did this placental screen. So again, at the mid-trimester scan, you're assessing for placental health, and they're looking at fetal growth restriction before 34 weeks, so early onset. And I don't know if you guys know rock curves and area.
Yes.
Yeah.
Yeah, we do.
This is quite a nice rock curve. If you look, the higher it goes to the top left-hand corner, the more accurate your test is. So it's sensitivity versus 1 minus specificity. And if you just have a 50-50 kind of, if you follow that line, you might as well not do whatever you're doing, because the accuracy is so poor. But as you get closer to 1, and this rock curve is 0.93, it's saying actually we're getting pretty accurate at predicting the babies we're going to have to deliver early. So that's quite a nice rock curve, just to show you sort of accuracy. And then there's another one, iatrogenic preterm delivery or stillbirth before 34 weeks. So like I said, those are proper obstetric outcomes. It's not like if he delivered at 37 weeks because it was a Friday kind of story. This rock curve is 0.86. So it looks like that this is a fairly accurate way of finding, not to diagnose, but to triage or find the ladies who are going to be at risk of this. Because it's always devastating when you spring this on the patient that they're ultra high risk for preterm birth and they had no idea, and they've got 4 days to get around that idea before the CTG goes off. Okay, so
Zoe,
yeah,
just to knock off another question, what's the best gestational age for uterine artery Doppler measurements?
Okay, so depends where you work and your resources. I think the most accurate, the best time to do it would be at the NT scan, so the 11 to 13 week scan, because if you screen high risk, that's when you start the aspirin. It's shown that if you start it before 14 weeks, it's got the highest efficacy for working. So definitely, without a doubt, at the NT scan is your bang for your buck, and you put your ladies on aspirin. If you do it at the 20-week scan, so in 1990s, fetal medicine or obstetrics, we all did it at the 20-week scan, but it's too late to start aspirin at that point. So if you can't do it then, if you can only do it once, I would do it at the NT scan. We check then at the anatomy scan to check that it's working, and then we can reassure the patient that the aspirin is doing what we've asked it to do, and the uterines have now normalized. I think that's very reassuring. And the patients who then really it hasn't normalized, we start talking, listen, we're going to start scanning your periviability, and you're not gonna make 30 weeks. I don't know if that's useful.
Yeah, thank you very much.
Yeah. So the 20-week for me, it would be a bit more historical, or if you're doing surveillance for an already high-risk pregnancy, which the uterines were already high at the NT scan. Okay. So that trial kind of showed that that you've got a high detection rate for picking up early fetal growth restriction, but it does have a high false positive rate. So you do need to look at the anatomy scan, because you can then down risk a lot of ladies and say, the aspirin's working, your uterines are fine, don't worry, you don't need increased surveillance until 32, 34 weeks. Definitely you can do growth scans with the general gynae once a month, but you don't need the intensive surveillance with all of the uterine artery Dopplers. But if, like I say, your uterines are still bad at the mid-trimester, you need to keep on scanning that baby periviability, and that viability will be different to wherever you work, but somewhere between 24, 28 weeks, whatever your viability is, and you need to start having a conversation of a 30 or 32-week delivery. Like I said, this is 2024 Nature portfolio, also looking at the efficacy of the PAPA and the free beta to predict preterm delivery. So this is the only outcome they looked at preterm delivery. They didn't say because of growth restriction, and they didn't have growth restriction as an independent outcome. It's just preterm delivery. But we know spontaneous preterm birth can also occur in if there's placental insufficiency, or if iatrogenic preterm delivery because of placental insufficiency that we know of. So this is saying, just looking at preterm birth and spontaneous birth and PPROM before 37 weeks, it's not, having a low PAP-A is not specific enough to have that, the predictive power isn't high enough. But I think you can't say your PAPA is 0.4 and you absolutely will deliver preterm. It's got to be a bit more nuanced, and you review at the 20-week anatomy scan. But it's interesting in patients who don't have access to uterine artery Dopplers in the first trimester. I think it can be a surrogate to triage the pregnancy to midwife-led care or home birth at 41 weeks with the doula, or maybe we need to start looking at this baby for growth restriction. Oh, sorry. Another practical example which absolutely breaks my heart, and I also see not as frequently, but this is a reality. Your typical non-vascular path patient, so young, healthy, she's 26, first pregnancy, she's slender, blood pressure is fine at booking. She conceived very quickly after getting married. She's got no comorbidities. So she shouldn't be somebody who has rampant growth restriction from 26 weeks. And then what's very common in South Africa, unfortunately for cost reasons, but also for the religious beliefs, they opted out of their first trimester, and it's sold to them or offered or advertised as down screening. So just a quick conversation with the gynaes, the NT scan is just for down screening. So they decided it makes perfect sense not to have the first trimester screen because they don't want to know about Down syndrome. It's not going to change the way they manage their pregnancy. Makes total sense. But we're also checking the anatomy, and for me, it's the preeclampsia risking, and there's a safe intervention, the early aspirin. So at this lady, the first time we see her is at 22 weeks. The fetus is structurally normal, low risk for T21, so no NT scan, no uterine arteries done, no PAP-A or free beta, because they don't want Down screening. But her uterine artery Dopplers are significantly raised. Starting her on ecotrin is not going to make any difference. We do fetal surveillance from about 25 weeks. Progressively, all the Dopplers go off. Baby is small, and she spends the last 2 weeks of her pregnancy in the ward working up for preeclampsia, and because the Dopplers are so bad, she has an abruption and has to deliver 30 weeks. So, and this we see at least once a month, if not twice a month. And maybe if I can reach out to the general gynaes to say we can prevent this happening. And I fully support patients opting not to screen for Down syndrome. But I think if you can do that preeclampsia screening at the 11 to 13 weeks, I think it's invaluable for parents who want to try and prevent preterm birth from placental insufficiency. If patients, at the very least, if patients opt out of the scan altogether, or there's no access to the scan, maybe, this is a bit controversial, patients who opt out of the NT scan and preeclampsia screening, and it's their first pregnancy, you don't know how they're going to respond to pregnancy, maybe those ladies you put on low-dose aspirin because you haven't excluded them being high risk for early onset preeclampsia. So this is a very common scenario, which I see a lot of.
Zoe?
Yeah?
Another question over here from Mike Suddens in Zimbabwe, Harare. This is your maternal fetal hat you're going to have to wear for this one. In patients at high risk for IUGR from early tests, is there any role for Clexane plus ecotrin or not?
Okay, so I would definitely say there's evidence for ecotrin.
Yeah.
They tried Clexane specifically in high-risk patients, so previously affected pregnancy. It doesn't make a difference in patients at high risk for growth restriction. The only evidence is moms who've got proven antiphospholipid syndrome, with the 2 sets of blood 6 to 12 weeks apart. There's some benefit. And the other patients to prevent recurrence or to prevent DVTs or venous thromboembolism in patients who have got a proper history or screen ultra high risk for that. So those for me, would be the indications for Clexane, not just fetal growth restriction.
Okay, then you just do the ecotrin. Thank you very much.
Yeah.
For that answer for Mike Suddens.
Okay. Then, so I would like to recommend that because these uterine artery Dopplers at the NT scan are not freely available for everybody, but the laboratories, most where there is a PathCare and AMPath, a Lancet, they will be able to do free beta and PAP-A. And I think you should be doing it on all your patients, irrespective if they want to screen for aneuploidy or not. And you can explain to them we're trying to prevent growth restriction. Those bloods should be taken at 10 weeks of gestation. I also think there's a role to do them if the patients already had their NIPT at 10 weeks and they've excluded the aneuploidy, but we can use them for the preeclampsia screening. Like I said, PLGF is more accurate than the PAP-A, but it's not as widely available and isn't covered by the medical aids yet. It costs about 1,000 Rand. Okay. Then, shall I open a can of worms? Second trimester biochemistry. I don't know if...
Yeah, let's open a can of worms.
Okay. So your second trimester biochemistry, which is also called the triple test, it's the total beta-HCG, estriol, and alpha-fetoprotein. So it's triple because it's three hormones. also all made by the placenta. And those bloods are taken later. So usually a patient who finds out they're pregnant at 14 weeks or didn't know and they're 16 weeks, now what do? We've missed everything in first trimester. We're stuck with second trimester. These are not accurate tests, and there are a lot of false positives, and they cause a lot of anxiety. So I just want you to be aware of a high false positive rate. And then they will be reported as high risk for Downs, or even worse, high risk for neural tube defects. And the patient can't even speak when they get into your consulting room because they've looked on the portals. You know, you go to your PathCare and it says high risk for neural tube defects. So the second trimester detection rates are lower than first trimester, not as accurate, but your false positive, it's properly high. Okay. I can just put in there that second trimester ultrasound markers are also fairly rubbish for Down syndrome. If you see somebody who's 38 years old booking at 16 weeks for the first time, just go straight to NIPT, because this is not a good way to spend anyone's time. You know, a 75% detection rate is really, it's not good enough for a serious condition that if the parents would really like to know about it. Okay, so
Zoe, so if a woman has missed the first trimester screening, she's missed the bloods and the whatnot, at the clinic, the secretary always asks the woman, "Have you had blood?" Hey, presto, the woman phones me and says, "What bloods must I do?" I have no idea what bloods. What bloods should she do? But you've said that those triple tests are rubbish. So is there any point at all in doing them if they're rubbish? Or does she need bloods at all?
Well, so you're still going to do your syphilis, your blood type.
No. But I mean the placental ones,
yeah,
not the syphilis ones.
Okay. Here's a bit of a debate. If you do second trimester biochemistry, they're about 850 Rand.
Yeah.
They are rubbish. They might, if you screen intermediate or high risk, that might get your medical aid to cover the NIPT. Okay, so that for me is the only reason to take these bloods, is to get motivation to cover NIPT.
Okay, got it.
Okay. You know, it's difficult. Like, let's say you're a 26-year-old and you book at 16 weeks. I mean, the debate of doing NIPT is probably, you know, maybe that's a bit far-fetched. But if you're 39 or 40, skip this and go straight to NIPT, I feel. Okay, that's my personal opinion. That's not guidelines, but this causes a lot of problems. Yeah. Okay. So then, so second trimester biochemistry, they're pulled between 15 and 18 weeks. So like I said, when you've missed first trimester, they really don't perform well. You can see the more powerful a test is, the more dramatically or in higher numbers they can up-risk you or down-risk you. And we get this so often where they stick around their background age-related risk. So then it really hasn't done a lot. So for this reason, I don't like it. They're not powerful tests. Yeah, like I said, 850. Okay, so.
And how much is an NIPT test just off the top of your head by comparison?
So if you do Down syndrome only, it's 3,900 Rand.
Okay, it's much more.
You know, you don't have to do the trisomy 13 and 18 because the chance that the baby's got those conditions and looks absolutely normal on scan is very, very low.
Yeah.
My worry is you do these 850, maybe the person could maybe afford the 3,900. But if you've already chowed up 850 Rand of their non-medical aid disposable for something that's not going to help them a lot. I think it's what we had in the 90s, but I think we should move straight on, particularly for the older mums, over 35. Pass, go, don't collect your second trimester biochemistry, go straight for NIPT. That's what I would say about second trimester bloods. Okay. It is more accurate if you add the inhibin, yes. Maybe that's useful in the younger mums. You know, you're 26 and you do a quadruple test. That might be able to get you motivation for your NIPT. But the triple test, I think, is a rubbish test. And in
Okay.
the age of NIPT, I don't think we should be doing it.
Okay. Here's another one for Akbakan. From what gestational age is the use of ecotrin no longer beneficial in the prevention of PET and FGR? Excuse me.
Probably, so the first world doesn't do proper research on this where the primary aim, so it was powered for this, but as secondary outcomes, it's probably from 20 weeks. It's
Okay.
becomes quite useless. So that's why I don't like the idea of you try an artery Dopplers for screening because it can't do anything about it. You just watch the natural history of the disease. There isn't a good intervention from 20 weeks. So some people do it up to 28 weeks, but that's not particularly evidence-based. I think the efficacy gets less and less. And there's a trend towards increasing abruption risk if you started very late. It's not powered for that, but there was a trend towards increasing your abruption risk if you started very late.
Okay.
Yeah. Let me talk about my old friend, alpha-fetoprotein. This was 1980s medicine. I know I sound so scathing about this, but I had to learn how this came into being. But alpha-fetoprotein levels are raised if there's an open neural tube defect, and there are tons of false positives. I think what's reported on the laboratory reports are, I think it's much higher than that. So we get reports that say 1 in 7 for a neural tube defect. That's ridiculously high. And the thing about this, it's highly dependent on accurate gestation. So in the 80s, where not everybody could get access to a dating scan, they would then get a high alpha-fetoprotein, but it was because the gestation was incorrect. So if you are interested in excluding neural tube defects, an ultrasound with a newer machine, it's got a detection rate of at least 95%. So, and the blood test can only offer you 80%. So if you want to know about spina bifida, rather do an ultrasound. It's a different ball game now to what it was in the 80s and 90s. And that's because the machines are getting so much better. You can see them a lot more. But importantly, so your patient is freaking out. Well, if it's not a neural tube defect, why was my level raised? It's raised in all, whenever the fetal there's an open fetal compartment. So gastroschisis, exomphalos, but interestingly, renal tract abnormalities. So even if you've got hydronephrosis or multicystic dysplastic kidney, you might get a raised alpha-fetoprotein. How about this? It's raised in placental damage. So the mom gets a bit of malaria or some other infection that will increase alpha-fetoprotein. It can be of maternal origin, and sometimes we don't even know why it's raised. So I would not put a lot of emphasis on the accuracy of this test. Okay. So like I said, the quadruple test, it is done same thing as the triple test, but you add inhibin and it increases your detection rate. So the only time I think this has value, maybe in a 26-year-old who you're trying to get her access to NIPT, maybe if that comes back as intermediate risk, maybe her medical aid will cover NIPT. That, for me, that's the use of doing those tests. Because if you've got a detection rate of 81%, that means that you're going to miss 19% of Down syndrome. So either you want to find out or you don't, but 19% false negative rate is, for me, it's not very useful. Okay. So my opinion, and this is my personal opinion, not a guidelines, I would, on second trimester biochemistry, I would avoid the triple test, maybe the quadruple test, but rather go straight to NIPT if the mom really wants to know. Also, we've seen a lot, if you get very low, it's also reported in moms, if you get very low, all 3 hormones, consider placental insufficiency, and then you can use your uterine artery Dopplers to sort that out, to see if that's the case. So, okay, this is my 1 or 2 last slide that I'd like to bring across the idea of placental biochemistry or placental hormones to triage the patient. So sometimes you get low-risk patients and you think it's completely appropriate to send them to sonographers for the NT scan. And sometimes you get high-risk patients who might benefit more from going to a maternal fetal specialist to unpick what's going on here. So previously we just did it on age alone. So young mums should go to sonographers and maybe the older mums go to MFMs because you're more likely to pick up the aneuploidies there. But the older mums, you're also more likely to pick up the vasculopaths, the chronic hypertensives, the diabetics, the obese patients. And I'd like to introduce the idea of using these first trimester hormones to triage where you send your patients for their NT scan. More recently, it's come out of it's gone out of fashion to request that the laboratory does the risk stratification with that alpha software, but you can ask that they do it. You just add the mom's weight and gestation, and they will calculate high risk, low risk, intermediate risk, and you can use that to triage where you want to send your patient for the NT scan. Because once you can exclude your aneuploidy with your NIPT, but you need to unpack why that PAP-A was low, or why the free beta was high. Was there a disappearing twin? Is it a partial mole? Is this a placental insufficiency case? So if you get very abnormal first trimester biochemistry, it might be more wise to refer directly to an MFM or somebody who's fetal medicine accredited, even if the patients don't want first trimester screening, because we often, if they're high risk for T21, they're going to be seen by the sonographer. Whoops, they scanned findings of T21, so they've had to pay the sonographer, and then they have to pay the MFM. So the patients actually had to pay not double, but 1.5 times, where you could say, hang on, this is a high risk result. Let's rather say go to MFMs to sort out what is the cause of these high abnormal results. So this abnormal placental biochemistry, these pregnancies are at higher risk for placental insufficiency, and we need to unpack the cause about it. Yeah, so perhaps, obviously I'm biased in this, but I think triaging the abnormal biochemistry to sonographers, it often does the patient a disservice, because the sonographer says, well, I can down risk you from high risk to intermediate risk, and now what? Or they don't know, sonographer can't unpack the history of autoimmune diseases or the family history of preeclampsia to try and figure out why these results are abnormal. So definitely don't learn the values for gestation, because they depend on the gestation, the mom's weight, everything. But if you want to get alarmed about a low PAP-A, 0.4 or 0.3 moms is probably where everyone's thinking the problems are going to lie in there. There's going to be an abnormal pregnancy outcome there. Whether it's an aneuploidy or placental insufficiency, you're going to get a problem there. So just remember your mom, multiples of the mean, you want that close to 1. So this is like 40% or 30% value of what it should be. So it's properly abnormal. If the PAP-A and the free beta are really, really bad, you've got to think about possibly a failing pregnancy or triploidy. And then the high free beta HCG, vanishing twin, or a molar pregnancy. So those are my thoughts about the first trimester biochemistry. And then, so just to summarize, last slide, I think all patients should get first trimester biochemistry, because to realize that it's not just the Downs bloods or the Downs screening bloods, it's screening for aneuploidy, but also for the preeclampsia risk. And that needs to go across to the patients who don't want Down syndrome screening. Yeah. And I wouldn't request second trimester biochemistry. I think if you're worried, you must go for NIPT. I think the first trimester anatomy scan should happen for all patients because of the preeclampsia screening, and also we pick up things like high spina bifida and encephaly. And parents might feel very differently about that kind of a pregnancy compared to Down syndrome. And even if we pick up an aneuploidy, which we think is not compatible with life, trisomy 13 or 18, even if the parents would never intervene, they might want to know about this, so they know what to expect and prepare themselves. So if they get a mid-trimester spontaneous IUFD, they would have a couple of weeks to prepare, and it doesn't come as such a huge shock to them. Yeah. And then, so the NIPT has changed the field for parents who are intermediate risk, or even parents who wouldn't consider TOP. It's nice to do them to look at trisomy 13 and 18. It's also going to help the obstetrician for their intrapartum level of intervention. So, you know, the parents don't want to risk a miscarriage with an amniocentesis, but we highly suspect trisomy 13 or 18. Do the NIPT so you guys know we're not doing an emergency 4 a.m. Caesar for trisomy 18. Yeah.
Zoe, thank you so much. It's been a wonderful talk. One very last question. If you don't have access to Ecotrin, what dose of aspirin or Dispirin do you use?
Okay. I think the most important thing would be the timing to start it. So if you're going to focus on one thing, try and start it before 14 weeks. That's your highest level of efficacy. And then somewhere, it's hotly debated, somewhere between probably 100 and 162 milligrams. Some people are advocating 81 milligrams, but probably more like between 100 and 162 milligrams.
Okay, thanks very much. That's if you can't get your Ecotrin, that's the dose to use. It's been wonderful, and we've had lots and lots of people, lots and lots of questions, Zoe. All I can do is thank you very much from the bottom of my heart. It's been wonderful, and I hope that next week we can meet you all again, same time, same place, for Dr. Percy Moodley, and thereafterwards Phil Zinn, that comes from your neck of the woods. He's speaking on vulvodynia. And a special thanks to Wendy, the technician that's on with this afternoon. It's made everything run so very, very smoothly. Same time, same place. Zoe, good night. Thanks again. And thanks to all the people for logging on.
Thank you. Cheers. Bye.
Bye.